Disseminated cysticercosis. First, what is cysticercosis? Cysticercosis is a parasitic tissue infection caused by larval cysts of the tapeworm Tinea. This larval cyst infects brain, muscle, or other tissue and are a major cause of adult-onset seizures in most low-income countries. A person gets cysticercosis by swallowing eggs found in the feces of a person who has an intestinal tapeworm.
Here we perform oral double balloon enteroscopy in a 40-year-old woman who was admitted to our clinic having experienced abdominal pain for nearly 4 years. Abdominal CT and a small bowel series disclosed thickening of the jejunum and ileum. She had previously undergone several diagnostic endoscopic examinations, including gastroscopy and colonoscopy, which were normal. The long white flat string that you see moving slowly in the distal duodenum is a tapeworm called Tinea saginata. Tineas are intestinal tapeworms that are only definitively hosted by humans. Indeed, in the present case, T. saginata are seen throughout the distal duodenum to the proximal ileum. This is a whole clue of tapeworms. The length of an adult worm is usually less than 5 meters. However, it may reach up to 25 meters, like in this case. An estimated 80 million people are colonized with beef or pork tapeworm. Humans become infected by ingesting raw or undercooked infected meat containing cysticerci. Most people colonized with adult T. saginata are asymptomatic. Those with symptoms complain of mild abdominal discomfort, loss of appetite, or change in stool pattern. At withdrawal of the endoscope, we can appreciate the gigantic worm burden within the small bowel. Praziquantel and niclosamide are effective treatment alternatives. In this patient, niclosamide treatment was started after diagnosis and symptoms resolved approximately 2 weeks later.
Now we are going to see how this parasite can get transmitted.
Tinea solium is a pork tapeworm that infects humans. Humans become infected after eating contaminated pork or through fecal oral exposure. Larvae from the tapeworm eggs migrate to muscle and other tissues, including the brain, which can lead to neurocysticercosis, a major cause of seizures in developing countries. Can the transmission of tinea be stopped on a population-wide level? Investigators implemented a 3-phase eradication program to eliminate Tinea solium from the villages of Tumbes province in Peru. Various screening and treatment strategies of both pigs and humans were conducted in the first 2 phases of the program to determine the most effective and practical interventions to implement on a wider scale. In Phase 3, over a one-year period, mass treatment was given to over 81,000 people in 107 villages, and more than 55,000 pigs received treatment and vaccination. Humans received a series of 3 doses of niclosamide, with 85% of the entire population receiving at least 1 dose during the intervention period. Pigs received oxfendazole every 2 months, along with tinea vaccinations. At baseline, the prevalence of pigs with tinea seropositivity ranged from 25 to 50%. After 12 months of intervention, 3,530 pigs were randomly screened, and 29% were seropositive for antibodies. Necropsies were conducted on 342 seropositive pigs, and less than 1% were found to have live, non-degenerated cysts, as compared with an estimated prevalence of at least 20% before the intervention. Thus, tinea solium transmission can be stopped on a population-wide level with mass treatments of both pigs and humans, along with pig vaccination. Full trial results are available at nejm.org.
So, the disseminated cysticercosis. This is a rare form of cysticercosis in which the cysticerci is spread out through the whole body. The usual involved organs are subcutaneous tissue, skeletal muscles, lungs, brain, eyes, liver, and heart. Now, the first case was a 39-year-old Mongolian with disseminated cysticercosis. He visited the Seoul Medical Hospital, which generalized tonic-clonic seizure. After extensive investigation from brain computed tomography, also spine magnetic resonance imaging, whole body MRI, and pathologic biopsy, he was diagnosed as having cysticercosis involving the brain, subcutaneous tissue, and skeletal muscles through the whole body. The patient was treated with albendazole, in which case the followed MRI showed that numbers of cystic lesions were copiously decreased.
Parenchymal and extraparenchymal neurocysticercosis should be treated with a combination of antiparasitic therapy and corticosteroids. The treatment of choice is albendazole 15 mg per kilogram per day in 2 divided doses, or alternatively praziquantel 50 mg per kilogram per day in 3 divided doses. The duration of therapy is dependent upon the number and location of cysts, namely 7 days for a single lesion, 10 to 14 days for multiple lesions, and at least 28 days for subarachnoid neurocysticercosis. Treatment should not be initiated in patients with only calcified or non-viable cysts. Antiparasitic therapy should be initiated in conjunction with corticosteroids, including prednisone, prednisolone, or dexamethasone, for 5 to 10 days, followed by rapid tapering dosages. The rationale for administration of corticosteroids is the reduction of immune inflammatory response and further damage to the surrounding tissues triggered by the death of viable cysts and the release of parasitic antigens by antiparasitic therapy. Given the high risk of seizure, parenchymal neurocysticercosis should also be treated with antiepileptic therapy. Treatment should be continued for at least 6 to 12 months after radiographic resolution of neurocysticercosis. Lifelong antiepileptic therapy may be necessary if seizures recur after discontinuation of medications. Surgical intervention is indicated in patients with hydrocephalus, mass effect, or ocular involvement. Lastly, extraneural cysticercosis should only be treated symptomatically with NSAIDs, followed by surgical excision if symptoms are bothersome and refractory to medical management.
Now, the pros and cons of the treatment. The pros, the advantage of albendazole over praziquantel is that the former also destroys subarachnoid and ventricular cysts because of its better penetration in cerebrospinal fluid, as well as the fact that it can be administered jointly with corticosteroid agents for anti-inflammatory therapy. And the cons, even though both regimens were treatable for the disseminated cysticercosis, the cysticidal drugs cause inflammatory reactions and may exacerbate the intracranial hypertension, which may cause the side effects such as headache, nausea, and vomiting. Well, this issue applied in Ecuador. Ecuador was the pioneer in the region in research for the search for a strategy of epidemiological control of TNS and cysticercosis. This was said by Juan Braño, a member of the Medical College of Pichincha, to medical writing. Now, the situation, the decreasing trend over time, is compatible with the observed by specialists in large hospitals in Ecuador and could be caused by the improvement of the general conditions of life, such as better sanitation and better access to medical care, with the general improvements in the system of health of Ecuador. Now, concluding, even though the disseminated cysticercosis is a very rare infection disease, it's recommended to investigate the spine and other organs to rule out the disseminated cysticercosis when multiple cysticercosi present in the brain and in a CT scan.
The International Task Force for Disease Eradication in 1992 reported that cysticercosis has a potential for eradication. Eradication is feasible because there is no animal reservoir besides humans for mature and larval stages, and pigs for the larval stage. Therefore, by directing preventative measures at breaking the cycle of Taenia solium, successful eradication may be achieved. Such measures should include health education, cooking and freezing pork to destroy cysticerci, improvement in personal hygiene practices, proper meat inspection, and mass treatment programs for infected humans.